Good afternoon, everyone. Welcome to the Saving Face breakout session, where we're going to talk about teeth, ears, and eyes. And as you know, this year's theme is Chapters of a Healthy Life. And what we've been talking about today and for the rest of tomorrow is about, the natural progression through the chapters of our life, and also some of the things that can interrupt the natural progression of a natural life and the impact that that has on us, and how that we can perhaps make some lifestyle changes in order to alter those things that would interrupt the natural progression. Because as we all know, unfortunately, aging is inevitable, right? And there are certain things that come along with aging, but there are some things that we can do in order to, slow down that process a little bit. And, we heard this morning from the presenter about the importance of nutrition and how nutrition really impacts the rest of our lives, and how we need to make sure that we pay special focus to that in the formative age of our life. So this afternoon, we're going to hear about teeth, ears, and eyes, and we're going to be looking at how the changes that is made throughout the aging and the chapters of our lives. We're going to be hearing from 3 local experts, and they're going to be talking to you about their area of expertise. Each presenter will speak for about 10 to 15 minutes, and then at the end, we'll do a question and answer session. Okay, and I'm going to introduce each one of them in a little bit, but I just want you to know that this session is being recorded. We have IPEC in the back doing the recording, so therefore afterwards it's going to be uploaded on our conference website. So if there are other sessions that you would have liked to attend as well, and obviously haven't been able to attend because you're in this one, you can also have access to that later on once it's uploaded on the website. Okay? If you can, just take a second to put your cell phones on vibrate or silent so that we don't interrupt the speakers. And we're going to have a coffee break session that is going to start about 4 o'clock and run until 4:45. So we'll decide, we'll see how we've progressed through the breakout session, and if we want to take a formal break, or do we want to just, take turns going out, grabbing something and come back in, okay? Because we're already at 3:30. Okay, so our first presenter is the gentleman on my left, Dr. Noddy Dreyer. Dr. Noddy is an experienced dentist with 34 years, of which 22 is in private practice in various countries and international locations. Dr. Dreyer has been the dental officer at the Marion's Dental Clinic at the Health Service Authority since 2007, and he currently has been working there at the Marion's Dental Center for the last few years. And prior to moving to Cayman, he owned dental practices in Namibia and Germany, including serving as a senior dental officer for public health services in Namibia. Dr. Dreyer specializes in many fields of interest and clinical experience, including cosmetic, aesthetic dentistry, dental implantology, endodontics, orthodontics, and facial orthopedics. He's also a member of the Rotary Central, and he's a board member of Junior Achievement. So without further introduction, let me invite Dr. Dreyer to come and share with you about teeth and its aging.
Thank you, everybody. Thank you for inviting me. When I was asked to come present here, I said, but there's a lot more learned people in health and in dental around here that is probably more suited to do this type of presentation. And the biggest challenge, I thought, was to try and fit the 70, 80 years that we see between those two pictures into a 10 or 15-minute presentation. The bulk of what I'm going to be showing you will be things other than what we all know, not to eat too many sugars, not to reduce our soda intakes, to brush our teeth. So we're not going to talk too much about those basics, but we will also not be going into any academics, because I know that a lot of people in the room are not dental care health professionals, and the ones that are here are only here to check on me that I'm telling you the truth. So without further ado, we are going to be running through the chapters of life, starting with the pregnant mother and the unborn baby, then look a little bit at the dental health and potential issues with preschool small children, then briefly at the school-going child, dividing it up in different sort of age groups and different developmental stages. Very briefly on adults, because I'm saying that the basics of basic dental health in the adult group sort of overlaps with these other age groups, so we're going to focus more on the younger child, where our preventative measures, I think, are way more important, and then on our seniors whose health picture is sort of constantly changing with new developments in the dental field, and also they tend to go through phases where they need different dental care again than the adult age group. What I've tried to do for the benefit of our non-dental participants, to highlight a few issues which I think will benefit prevention of dental complications at different stages in these different chapters of our dental development. So starting with a pregnant mother, I think we all realize that pregnancy is a very unique time in a woman's life, and it's characterized by a lot of complex changes. But from my perspective, in 35 years of dental work, I also see it as a very, very important stage of trying, from the overall healthcare profession, to influence the dental healthcare straight at an early stage during pregnancy. The one basic thing that we need to understand is that dental caries, which is one of the earlier dental diseases that affect children mainly, is a common bacterial infection, and to a large extent a preventable bacterial infection. There's a lot of scientific proof that shows that kids of pregnant mothers with bad teeth or bad oral health are more susceptible to caries, and mainly because the bacteria that cause caries are transferred from the mother to the child at an early stage. But I think the most important thing, the message that I want to bring, is that I want pregnant mothers to understand that it is the early time to start influencing their child's health, but it's also very important to look at the quality of the mother's time during pregnancy, and that if patients learn that they are pregnant, I want our healthcare providers to encourage them to understand that dental care is safe during pregnancy. We find that a lot of people run from dental care because they are nervous about other things, and through that also nervous of dental care. The most important thing for this phase of their dental development is for them to understand that dental care is safe throughout pregnancy. The first trimester, we can do all sorts of diagnostic things, so I want us to encourage pregnant mothers to come relatively early in their pregnancy so that we can at least assess them. The safest period to do treatment is in the middle trimester, between the 14th and 20th week. We would generally not do treatments that are not necessary during pregnancy, but as shown at the bottom of that slide, that delay of necessary treatment could really result in significant risk to mother and the unborn child. So the message here is it is safe, and they should be encouraged to come really early to start the path of dental care and development. As far as the unborn baby goes, I think mothers often have a question about using supplemental fluoride. I will get back to that issue, but at this point, I think it's only important for you to understand that it is not currently recommended for pregnant for mothers to take additional fluoride in most regimes all over the world. There are different approaches to this, but generally the approach is not to give the mother supplemental fluoride, but I'll get back to that later. So the first baby phase that we're looking at probably contains also the most important message in my whole presentation. It's important that we, from the moment that they get their first teeth, we try and help them to clean their teeth. In a small baby, it is sufficient to use a very soft brush or a soft cloth to clean their teeth. And there's also no reason why we cannot help them brush their teeth with a tiny, tiny little bit of toothpaste. Even an adult toothpaste that contains fluoride will be beneficial to them. What we see in the bottom picture is what we call baby bottle caries syndrome. And like I say, the red flag there says, we realize that mothers want to care for their babies. But we also realize that very mothers, in meaning well, would give their babies something sweet in a bottle when they put them to bed. And that is one of the most dangerous things for chapter number 1 of the baby's life. There's no reason why they should have any sweet stuff in contact with their teeth over prolonged periods. So red flag number 1 is avoid putting the child to bed with a bottle or a sippy cup containing anything than water. I cannot emphasize that enough, because the damage that is done early is often carried forward through all of their dental lives. We're lucky in dentistry, unlike my colleagues with eyes and ears, that we get a second chance with a second set of teeth. But I will get to why that is not as easy as everybody thinks. So the message for the small child, the second message is that we, as generally, should limit sugar intake to meal times. And because of the danger of transferring bacteria between patients and between mother and child and between siblings, try and reduce saliva sharing behaviors, which I know is easier said than done. But it's also not the end of the world, because those bacteria are prone to be a part of the child's development in any case. So it's more important that we teach them to clean and help them to clean relatively early. So in terms of a first visit to the dentist, most regimens around the world now say the first tooth is the first opportunity. So we say between the ages of 6 months to a year, when they get their first teeth, it's okay to bring them. First of all, to have a check if everything is okay, and second of all, to start enforcing that right behavior. The one other thing before I get to this, if I may go back one of the biggest problems that dental healthcare professionals have is fear and anxiety. As you all know, everybody's scared of the dentist. I keep telling them rather be scared of the reception or the nurse, but not of the dentist, but it is unavoidable. But one of the things that we find is that parents transfer their own fear and anxiety to children unnecessarily. And children are sharper than we think. So if mum is on their way to the first dental visit and she says, "Oh, there's no need to be scared," child sits up and says, "Scared of what?" So that is another tip. Don't transfer any parental fears or anxieties to the child. Let the child be themselves and let them make their own experiences at the dental office. We've recently, from the northern US and Canada, had some news that flossing is no longer recommended. I was not going to go there, other than to say that a lot of issues are sometimes made controversial without having to be controversial. The whole flossing issue is actually a question of there's not enough evidence to support that it is good for you, but nobody has ever said that it's bad for you. And that's about all that I'm willing to say about that. It's political more than anything else. Another such topic that has been with dentistry over the last 50, 60 years is the use of fluoride to prevent tooth decay. And it's a pretty well accepted and undisputed fact that the tooth development benefits from fluoride. Ideally, the fluoride content in the water should be about 1 part per million, or 1 milligram per liter of drinking water. Now in Cayman, as you can see at the top, our water, and that is as recent as this week from the Water Authority, is 0.01 milligrams per liter. The problem with fluoride is that it, in too high doses, can be detrimental. It can cause staining to the teeth and other medical and health issues if we should overdose with fluoride. But I would be remiss in not addressing the issue of fluoride. I think in Cayman it is not wrong to give children a little bit of supplemental fluoride. But there's one caveat to that, and that is if they don't drink well water. I know that in some places in Cayman, some kids drink well water, and we don't have a lot of scientific research as to how much of that is prevalent. But what I do say, what I have seen in my own practice in the 10 years that I've been here, is that sometimes we do find that kids have staining of their teeth if they are exposed to well water. So the topic of fluoride, my opinion is that it is not wrong to give them small quantities of fluoride, but it is something that you need to research properly and discuss with the, professionals who know about it. There is also guidelines from PAHO, which says it is a topic that needs to be addressed with care. So just to touch on that topic. Another thing that we find that parents and caregivers often don't understand is that children develop slowly in terms of their ability to, for instance, brush their own teeth. I put this slide in to just illustrate that at the age of 1 and 2, children can often use a spoon, but they spill and they're not very good at it. So their fine motor development allows for them to only be able to cut with a pair of scissors and things like that around the age of 4 or 5. Why I put that in there is to stress the fact that they need assistance as small children. I think letting them be and letting them develop is a very, very good thing, but it makes a lot of sense to help them brush and make sure that they are brushing fairly effectively, or as well as we can. Small children in the US have, in some areas, up to 70% of caries at a very, very young age, and that rate is higher in minority and poorer and rural populations. So it is important that we understand that it's an infectious disease and it is preventable. So helping them brush and reinforcing the right behavior early is important in small children. Another thing that I wanted to put a little red flag on is the dental abscess of the deciduous tooth or the milk tooth. Very often goes unnoticed because it can be, in some instances, pretty much asymptomatic or just cause very, very minor discomfort. So it's important that parents look when they do help the kids brush. First, help them make sure that they brush their teeth clean as they can, and also look out for these little gum boils or dental abscesses, because they are treatable, and it's important for us to try and retain those teeth to prevent further problems like orthodontics and braces at a later age. Another topic that we faced with the 0 to 5-year-olds is the use of pacifiers or sucking their thumbs. A lot of it is non-nutritive, as at the top there. It's a question of giving them comfort and security. The American Association of Pediatric Dentists recommend the use of a pacifier rather than the thumb of the 0 to 5-year-old, and to start trying to break the habit at the age of 3. And I think the reason why they say a pacifier is better than a thumb is we can take the pacifier away. We cannot take the thumb away. It is a very, very difficult habit to break in children older than 4 or 5 years. So that is one little red flag tip. If they do get very comfortable with their thumb or the pacifier, try and address it early. The next stage was probably the more difficult one for me, because we all know that our children and youth develop from very cooperative little da and da-das right through to no, me brush my own teeth at 3 or 4 years, right down to why do I want to or have to brush my teeth at all. So the stages of development and cooperation in children can be and is really problematic. I think the most important thing to realize, and we've heard that in more than one of the lectures over the last day or so, that the children don't necessarily understand the consequences of their actions. So if they don't brush, they don't understand. It doesn't help for me, which I often do, jokingly tell them, brush those teeth that you want to keep till you're 90 and don't bother with the rest. They don't have that sort of perspective of the future, and the implications of not brushing is not really clear to them. So it's a very difficult time. At this time in their development, trauma is one thing that can be problematic for their primary front teeth. Most of the trauma that they do experience, 50 to 80% of it, of the trauma that we see in small children, is their upper front teeth. It makes sense to try and protect those if they start partaking in sport and their teeth is sort of prone to injuries maybe, but it is a very difficult thing. Sometimes it is also caused by some orthodontic problems in that the front teeth are very protrusive. One of the reasons for that is if they suck their thumb too long, it takes a long time for the first adjustment of the teeth to occur, and their little teeth when they first come are sometimes a little bit sort of protrusive in their mouths, and they're more prone to trauma at that stage in their lives. And another thing that also starts in that chapter of their lives is the question of braces or not braces, orthodontic treatment. And the only thing that I really wanted to highlight here for the benefit of our audience is it is probably just as bad as that baby bottle caries syndrome. When I was preparing this presentation, I thought, what are the things that I wanted people to really remember? And the one thing certainly is that we are not doing our babies a favor by giving them anything sweet. They don't know the difference. If they get used to drinking water when they go to sleep, they are quite okay to drink water. So mother's good intentions does not take them anywhere. And the same thing, unfortunately, the same big area where we often see nearly catastrophic problems with teeth is when they wear braces and they're not cleaning them properly. I think it is a relatively dangerous time too. So if children are in that phase, it's important that they see their dental professionals often. I think some of the worst cases that I've experienced in my 30-odd years is where the child has braces and they don't go back to their dentist or orthodontist for whatever reason. Sometimes it may be financial, sometimes it may just be a compliance issue, but it is a dangerous time keeping them in braces if they are not properly cared for. So I just wanted to highlight that at this stage. And then we get to the age of the selfie takers, which is another really difficult age because they start engaging in all sorts of new behaviors. One of the things that we are seeing increasingly are oral piercings that are not really researched all that well. We see cases where a piercing in the tongue would strip the gum from the teeth. If there's constant contact, it can damage the teeth, but if anything, it damages the soft tissues more often than not. If the piercings are done so that the balls of the piercing, because these piercings often have a titanium ball on top of the tongue and underneath the tongue. If those are in contact with the teeth constantly, it can do quite a bit of harm. And then obviously, if piercings get infected, it can turn out quite nasty and cause quite a bit of scarring of the tissues. Another thing that is not really well researched is the use of e-cigarettes and vaporizers and hookahs, but those are the things that are influencing this age group. They are also relatively uncompliant still in their treatment. I have found that I personally like to work with them because they are often not expecting it when we engage with them in a positive way, albeit sometimes having to break the ice with joking with them about their behaviors and things. I find they respond better to that than trying to force them to be compliant, but it is a difficult age. The one thing that they are prone to is the start of periodontal disease. If you look at the picture on the upper left, periodontal disease, unfortunately, is a very incipient, dangerous thing because the first signs of it are sometimes missed. You'll see a slight little red edge around the gum line, which are the first indications of gum disease, what we call a gingivitis, and it can gradually progress to a stage where the gums recede, the teeth drift, the teeth go longer. There's no need for anybody to grow longer in the teeth. These are, again, bacterial infections that are preventable. So the most important thing in that age group is to look out for the first signs of it, which is the gums bleeding, a redness around the neck of the tooth. But we do not have the time to go into all the treatment and other modalities. I think I wanted to just sort of show different stages, different chapters in line with the conference theme. There's a lot to be said about how to treat these things too. So then Miss Teresa, I told you, come sit in the front, you've got to be a good girl. So in terms of the next chapter, which is our adulthood, there's another whole spectrum of things that can be discussed. I think what is important, and the most important for today's discussion, is that our oral health very much reflects our other health or our general health situation. There are now a lot of other health issues like diabetes, heart disease, strokes, and pneumonia that are linked to gum health mainly. So people with periodontal disease are sometimes prone to these other adult diseases, and taking care of the one often helps take care of the other. And the last stage of our dental chapters is our seniors. And I think we are increasingly seeing that because of cost issues and because people, elderly, don't realize that they still need to be checked for things like oral cancers, they would tend to not visit the dentist as regularly anymore as they should. Sometimes they have dentures, pretty much ill-fitting, but they cope with them and they don't go to the dentist for many, many years. And that is a difficult thing in that sometimes oral cancers can be missed in that age group. I think when I qualified 30 years ago, a good 30+% of adults had full upper and lower dentures. That number is going down quite dramatically, and it is good so. We have things these days like dental implants and ways of restoring and maintaining the patient from going fully edentulous, as we call it, going to a full denture. But that, again, was not really the scope of what we're trying to discuss today. What I wanted you is to take away a few sort of pointers as to which chapters of our life we are at risk to what type of things. The main thing is that we need to understand that our seniors, even if they don't feel like going, they can become a little bit like children, as we all know. We still need to encourage them to have their dentures checked and reinforce the importance of checking for different stages of gum disease. And in the bottom center picture, you see a lesion of the gum or the lip, which very, very often in the elderly nowadays goes unnoticed until it's late. That is very often a sign of oral cancer, which is at the bottom there. So the message is that our adulthood, the oral health is important for a number of other systemic diseases, but to round off the discussion of the different chapters, diabetes is a big risk factor in our seniors, and it is now pretty well known that diabetes is a risk factor for periodontal disease, so diabetic patients tend to have more gum disease, gum infections, and gum problems related with their healing that is slower than in the non-diabetic patient. And the other way around, people with periodontal or gum disease is more prone for diabetics. I think I should have put another red flag in there. So that is to round off the discussion of the seniors and their problems. One of the biggest dangers that they face is oral cancers. And there's a red flag at the top says, a sore in the mouth that does not heal needs attention of any of our healthcare professionals to look at it. These things often go unnoticed, unfortunately. And it can lead to very severe resections, like the fellow at the bottom. It has a 5-year survival rate of only 50%. So early detection of oral cancer, I think, is one of the most important things we need to look out for in our seniors. And that brings me to the end of the chapters of our dental life. Thank you very much.
Thank you very much, Dr. Dreyer. Our next presenter is Dr. Annette Stevenson. She's the first Caymanian Doctor of Audiology and a graduate of Nova Southeastern University in 2005. Dr. Stevenson is a fellow of the American Academy of Audiology and a board certified by the American Board of Audiology. She established Cayman Hearing Center in 2007 to fill a much-needed area that was lacking by providing complete hearing healthcare services to the island. Dr. Stevenson offers educational seminars for physicians and patients is a trusted hearing specialist. Her clinical philosophy is one of individualized care and attention with personal touch for all patients. In recognition of her extraordinary contributions to health services in the Cayman Islands, she was awarded with the Emerging Pioneer Award from the Cayman Islands Ministry of Health. I'd like Dr. Stevenson to come and speak with us now about audiology. Thank you.
Hi, good afternoon, everybody. Thank you for taking the time to come out to our talk today. I do not have any PowerPoints, but that's fine, and I'm going to be about 5 minutes. As long as y'all can hear me, we good. The first question I get is, what is an audiologist? Basically, I am the non-medical hearing specialist. So I do not deal with any medical related issues to deal with your hearing. I deal with hearing imbalance. So when you can't hear and you're dizzy, you come see me. Unlike Dr. Dreyer with the oral health, there's not very many stages with the development of hearing. The hearing nerve is developed at probably around about 7 months gestation, so everything is fully formed. The biggest thing with hearing is hearing prevention. We don't have any fluoride, we don't have any ear brushes, we don't have anything like that. You just got to protect your ears. Just a little bit of statistics on the prevalence of hearing loss, because another misconception people think is that hearing loss is just in the elderly, and that is actually the opposite. The majority of patients that have hearing loss are under the age of 65. So, in fact, 3 out of 10 people over the age of 60 have hearing loss. 1 out of 6 baby boomers, so that's age 41 to 59, will have hearing loss. 1 out of 14 Gen Xers, which are the 29 to 40-year-olds, will have hearing loss. 1.4 million children under 18 have hearing loss, and 3 out of 1,000 babies are born with a serious to profound hearing loss. So as you can see, hearing loss is not prejudiced. It will affect everybody. So the majority of hearing loss is in 65% are younger than 65 years old. In the US, we don't have any stats here in Cayman, but in the US, there's 6 million people between the age of 18 and 44 that have hearing loss, and more than 1.5 million are school-aged children. So the biggest thing that if you take nothing else away from being here today, the one thing is to protect your hearing. Whenever you go in anywhere that's noisy, you wear earplugs. And I know it doesn't look cool to wear earplugs. Okay, yeah, fine. But it's better than to have hearing loss. Noise exposure is the #1 cause of hearing loss. And that also means it is the most preventable type of hearing loss. And then some symptoms of hearing loss are if you're asking people to repeat themselves, if you complain that people are mumbling, if you turn the TV up too loud, if you turn the radio up too loud. And if you notice family members starting to withdraw from social activities and not wanting to come out, not wanting to come to dinners, not wanting to come to functions, that could also be a sign of hearing loss. And so let's get back to the noise. Stay away from the noise. Whenever you're exposed to noise, some of the cool. I have no idea what that is, but okay, we'll keep going. That's some noise, woohoo, yeah, okay. Did you hear that? Perfectly timed. When you've been exposed to noise, you will notice a couple of things. Your ears are going to feel kind of stuffy and full. You'll notice them ringing, and you'll notice that you're not hearing as well. And that's called a temporary threshold shift. After a couple of days, your hearing will come back. We don't have a second set of ears, and we don't have a second set of auditory nerves. Once your hearing is gone, it's gone. It's not coming back. The nerve does not regenerate. That is the only nerve in the body that does not regenerate is the auditory nerve. So once it's damaged, and there's nothing you can do to bring it back. And that is why we stress the hearing prevention. So you wear earplugs. The foam ones at the pharmacy are great. You can get custom ones, that's fine too. But the biggest thing as far as throughout the ages is to protect the ears. We have a lot, as you see, a lot of hearing loss is happening in younger ages. We have the iPod, iPhone, all these things, and the kids are playing the online games and got the headphones on, and they're not being monitored to how loud they're turning up the headphones. If you have children around, or even yourself, and you are listening to headphones, if the person next to you can hear it, it's too loud, turn it down. And don't listen to it for any longer than 30 minutes. So 30 minutes on, 15 minutes off, because you want to prevent any damage to your hearing, and that's what you do. Yeah, and that's all I have. Thank you.
Thank you very much, Dr. Stevenson. As we've heard from both the presenters, both Dr. Dreyer and Dr. Stevenson, there are certain things that we can do to mitigate the degradation of our senses, both teeth and hearing. And that's what we want you to make sure you take away from this session this evening. Our next presenter is going to talk to us about our eyes. And that is Dr. Jake Lobert. Dr. Lobert studied medicine at Oxford, then Cambridge universities. Following a brief period in the British Army, he completed postgraduate specialist training in ophthalmology in London at Moorfields Eye Hospital. And he has subspecialist interests in glaucoma and took fellowships in Geneva, Switzerland, as well as King's College Hospital and St. Thomas Hospital in London. He's a keen diver and lionfish spearer. And when it's too windy to dive, he kite surfs. To the consternation of other divers and kiters, he maintains that he would actually rather be addressing a challenging cataract or glaucoma case than either diving or kiting. So Dr. Lobert, thank you very much for joining us to talk to us about vision.
So I'm going to talk about one aspect in particular of the eye, which is the lens, partly because it affects all of us. When you're young, you've got this lens which sits inside the pupil, the black bit in the centre of your eye. When you're young, that lens is transparent and it's rubbery. The reason I got this picture of the kids on the bouncy board, I don't know if any of you are key cooks, but if you've ever looked at a fish eye before you cook it, cut open it, you'll see inside there's that little lens. Sorry. There's that little lens, and it's quite easy to deform. It's quite rubbery. You can squeeze it and it bounces back into shape, a little bit like these bouncy balls. And that in itself can cause some issues in young children, but it's not young children I'm going to talk about mainly. Young kids can squeeze their lens a great deal, and that can cause squintiness that can be corrected by glasses like that. The problem with the lens as we get older is that it continues to grow. Unlike our hair and nails, which we can clip, the lens continues to grow inside the eye, and there's no way of shaving it off, of stopping it from growing. And eventually it outgrows the space which it has to grow into, the capsule, and it just hardens. Rather than getting very much bigger, it just compresses down. There have been ways of classifying the aging lens into 3 stages. The first that happens between the ages of 42 and 55, the lens becomes increasingly rigid. So the ability of the muscles of the eye to change the shape of the lens reduces. So that's when you start to need reading glasses, and many of us who are over 42 are beginning to get to that stage. And you need either reading glasses or to hold your reading material further away from you. So you can see that, if you don't need glasses, you have to have somebody else to hold your reading material for you. And you may notice as you get older that near point, the point which you can focus up most closely, starts to move further and further away. The next stage, between the ages of 55 and 70, is the color of that lens changes from a clear, transparent lens to yellow-brown, and that can cause the beginnings of problems with night vision and driving at night. Reading without proper illumination becomes difficult. And the first symptom that most patients I speak to in this age group complain of most is glare at night. So if you can see that picture at the bottom there, oncoming vehicles become a pile of light. Finally, over 65 to 70, the lens isn't only yellow-brown in color, but it becomes opaque and scatters light. This is the point where the vision, when you read it on the chart, starts to become reduced. And night vision and vision in poor lighting conditions is definitely reduced. The most famous person to suffer from cataract was Monet, the painter, and you can see he painted this bridge many times throughout his life. And when he was young, he had a nice picture of a bridge there, and as he got older, it became more and more of a mess, the same picture from the same side, and he painted it more than a dozen times, and you can see the progression of his cataract as he got older. And that's what a cataract looks like. That lens inside the pupil there is no longer transparent. It's got white bits in it, and it's a browny yellow color. When we think about cataract, when I tell a patient they might have the beginning of an early bit of cataract, we often think of the upper picture, the very elderly person, often in the third world, who's almost blind. But actually, the time when we think about having cataract these days has changed quite a lot. And I downloaded the picture on the bottom there from an American ophthalmologist website where they think about having good vision over the age of 40, and it's a very different idea as to what the dysfunctional lens with age is. Everybody's lens, if you live long enough, will suffer from these problems. It's not a disease so much as just the changes that happen with age. And there's actually not much you can do to stop that from happening. It will just happen to all of us. The one thing that we can do to solve these problems is cataract surgery. And as cataract surgery has become increasingly safe and well tolerated, and complications are now very rare, we can use cataract surgery to address the problems of the aging lens at an earlier and earlier stage. It's very effective at addressing the problems of stage 2 and stage 3 when the lens starts to become opaque. The one thing it can't do is it can't return the lens to that rubbery, deformable, youthful lens. Cataract surgery can't do that. The added thing that cataract surgery can do is if you need glasses, if you are long-sighted or short-sighted. When you do cataract surgery, you have the option to put in any lens you choose, and you can put the right lens in to leave you without the need for glasses. So people with the glasses prescription are often opting to have cataract surgery early in order to get rid of glasses. So as the complication rate of cataract surgery gets safer and safer every year, new technology is coming out, and really complications now are extraordinarily rare. So doctors are opting to intervene and remove lenses at a younger and younger age now, as soon as vision becomes a problem. And that's the end result. That's what a clear lens inside a pupil looks like with a picture. So the take-home message really for cataract is that it's not the very old person or blind person's disease that it once was. I think we're addressing cataract at a much earlier stage, and people are benefiting therefore from good vision at a much earlier stage of life. So it's worth, in your 50s and 60s, seeing an ophthalmologist if there's any visual problem and getting any cataract that's there addressed. Thanks.
Thank you very much, Dr. Lobear. We have a few minutes so we can actually entertain some questions, if you have some questions for either one of our panelists. We have a mic in the back, and if you just raise your hand, someone will bring the mic to you. One question.
Good evening. I have a dental, first I have an ear. I heard you said you're not a medical doctor, so probably you might not be able to feed me on this, but my generation, I find out that they have a ear problem. Most of them deaf at a certain age, and so I'm concerned, how do I prevent such
Hearing loss.
If it's, there are types of hearing loss that are genetic. If the majority of your family members are female, and
yes, female,
and they have the hearing issue, unfortunately, there's nothing that you can do there probably isn't anything that you can do to prevent it. There is a type of hearing loss that's associated with the bones in the ear that go along with osteoporosis. And it's more predominant in women. So if the majority of the women in your family that have the hearing loss are women, then the likelihood of you getting the hearing loss is higher than if it weren't. And that's something that unfortunately we can't prevent because it's hereditary.
Okay.
Yes.
That's okay. Thank you. Dentist now. I was hoping you would say something about sickle cell patient with, not the dentist, yes. I was hoping you would say something about sickle cell patient with high problem.
Okay, I'm happy to.
To the mic.
So there are some issues with the retina and sickle cell retinopathy. And there has been some controversy over whether screening people with sickle cell disease is valuable or not. And my understanding of the current state of play is that there's no great benefit in catching problems at the retina early because there's no prevention that can be undertaken. So whilst there was a time when we used to see people with sickle cell and screen them to see whether they had any retinopathy.
Yeah.
I think the conclusion from years of experience is that actually, if they see well, then there's no problem that's worth addressing, obviously, because they see well. And if there's a problem with the vision, then it's worth addressing only at that point. So whilst it would be lovely if we could prevent problems of sickle cell retinopathy, I don't think there's any evidence that there's treatment that prevents problems other than preventing sickle cell attacks, episodes, which is useful anyway.
Okay, thank you. Okay, I think I'll visit the dentist because I get all of.
Thank you very much. If I could just go back to Dr. Stevenson. The question was if there is a way to prevent hearing loss, but maybe you can touch on a little bit about if there is hearing loss, what are some of the solutions?
Right. Well, yeah. If there is a hearing loss, 95% of hearing loss is non-medical, and so then you come see me. For the 5% that are medically treated, then you don't come see me. But for the 95% that are non-medical issues with hearing loss, the 95% of that 95% can be treated with hearing aids. And then there's a 5% that are not candidates for hearing aids. So hearing aids will be the course of action to take.
Okay. Question? Oh, there's a question in the back and then one in the front.
I have a question for Dr. Dreyer. I have a 3-year-old who still has his milk teeth, but not all of them have come out. And I was wondering if I should be concerned about it, or he's gotten his regular checkups with the dentist and everything, and I keep an eye on it. But as a mother, I wanted to know if this is something I should be worried about, or is this going to affect his actual adult teeth? Is he going to have an issue with those all coming out, or is this something that's common?
Yeah, it's not something that's uncommon. I don't think it's anything to be too concerned about. And this is anecdotal just through my experience, I have gotten the impression that my patients where the baby teeth erupt late are normally late in their cycles of getting their permanent teeth too, but they, for some reason, seem to have stronger teeth generally. Just my feeling over the years of seeing the sort of questions arise about getting their teeth later. They should normally be getting their first teeth around 6 months, and they should be have all their baby teeth at about 24 to 28 months. So if they're later than that, they are late, but there's nothing you can do really. And you don't have to be too concerned. Like I say, I've found that it's actually not a bad thing.
Thank you.
This one in the front.
I have a question for Dr. Stevenson. When you mentioned the point about like when we're listening to music or say we have in our earphones, what is an appropriate level of volume? Like, you know how it goes up to 100? What is the appropriate level of volume that you're supposed to listen?
So it's hard to say what number. I can't give you a number. But basically, if you turn it up and the person next to you can hear it, then it's too loud. And whatever number that is on your device, then that's the number it is. But I can't give you a number on that. Okay.
Thank you.
Thank you.
My question is for the dentist. In the adult years, the teeth do change color, I'm told. Is it a safe thing to whiten your teeth?
Yes, I think the current ways of bleaching, whether it's home bleaching or professional bleaching, has been shown to not be really detrimental. What it does is it just changes the reflection of light from the surface of the tooth, so it's not really something that penetrates into the substance of the tooth normally. It can cause a bit of sensitivity, which is often caused by a bit of loss of fluoride on the tooth surface, but it can be supplemented by using additional fluoride topically, or often by using something like a Sensodyne overnight, little bits of, that is something that I could have and should have maybe briefly addressed. A lot of tooth sensitivity these days can be treated very nicely with toothpaste like Sensodyne or any other sensitive toothpaste. But what I recommend for patients to do is leave it on the tooth longer. Leave it on the tooth when you go and watch your TV, or even dab a little bit of fluoride toothpaste on the sensitive tooth when you go to bed, because it's not really going to harm you that much swallowing a little drop of toothpaste, but leaving it to work on the tooth takes the sensitivity away. So yes, bleaching is not dangerous, and if your teeth do become sensitive, there's ways of handling it.
Any other question?
Hi, gum disease, gingivitis. Just saying, I know an adult, 4 or 5 years probably, I'm saying that's what he has because his teeth looks like that. He hasn't been to the dentist to get any treatment, do any cleaning. What if he goes and get it treated? Is it like, would he have tooth loss or?
Generally, we can never bring back loss of tooth structure, of the supporting structures. So if somebody has had gum and periodontal problems over longer periods of time, their gums will tend to recede, and we can only slow that process or stop it. If we can get people to be pretty much bacteria-free and infection-free, and the way to judge that is whether it's swollen or whether it's bleeding, things like that. If we can reduce or eliminate that, we can at least stop it. So we can even find the teeth go mobile a little bit because of lack of supporting structure, but treating it can make them go more rigid again. So we can at least delay that disease process. The one thing, unfortunately, about it is if you catch it early, it is pretty much reversible also because of the shape of the gums. But if you leave it too late, you get what was in that middle picture of mine, changes in the contour, changes of the supporting structures that are sort of making it not the regular gum form that you would expect in a young person's teeth. When you get to that, you get to deeper pockets, and that unfortunately feeds a little bit on itself like many other infections.
Okay, thank you.
There's one here and then.
I have 2 questions. The first question is for the dentist. With regards to flossing, you mentioned earlier that it has been said that flossing is not advantageous anymore, or it should not be continued. The second question is for the eye doctor. When do you recommend that we have our eye visits? Is it yearly or every 2 years?
Shall I go first? The whole flossing controversy, if you read it, it's actually pretty much political more than anything else. It was the media challenging the American guidelines about flossing. There was a decision some years ago that the American agencies can only recommend a procedure if it is so-called evidence-based. And what the Associated Press did is they went and challenged whether there's enough evidence, and it was found that there was not really enough evidence. But they've not done the same thing with brushing your teeth. Why is somebody not saying that you shouldn't be brushing your teeth? It is political. If you read the details of it, there's no scientific evidence to not floss your teeth. It is any way of cleaning in between your teeth is better than not cleaning them. So if you read the controversy there, it's a more of a agency and guideline type thing than...
I have not really looked at the study, but my colleague beside me, she's saying that the World Health Organization, they have done this study. However, what I'm trying to say, we have been told over the years that flossing has great benefits. And now, there is a new study indicating that there is no scientific evidence. People will not have confidence anymore when the dentists say you need to do this and you need to do that to ensure good dental health. And so I am wondering what kind of message we are sending to the public in that people don't know who to believe anymore.
No, I think what we need to understand is there is no study that says that. It's a media thing. This whole thing was started by the Associated Press. It was not, there's no really scientific evidence that says it is not good for you.
Right.
Yeah.
No, so I think the message is we continue flossing.
Yeah.
I think we had one more question, the gentleman in the red shirt.
Sorry,
Oh, I'm sorry.
so
Yes,
the
Dr.
second
Gobert.
question, if I've got it right, is when should we get our eyes checked?
How often?
And I think the first point in life where we ought to be picking up problems with the eyes is at first attendance at school, so at 5 years of age. And there's a program in Cayman of simply checking whether kids can see out of both eyes at first school attendance. And that, I think, is important. The question you ask is when should you get your eyes checked? And I think there are various levels of checking. I think the most common way is to attend an optician. And Cineco certainly funds a check every 2 years, and I think that's about right. And then to see an ophthalmologist if there's a problem that the optician can't correct with glasses. But every 2 years is really the answer to that, and certainly at 5 or before the age of 5 at some point.
Okay.
This question is for the eye doctor. Is reading glasses recommended? How long it should be worn before you get prescriptive lens?
So reading glasses are there for your own benefit. There's no long-term benefit of using them or not using them. So if you can't read without reading glasses, then you need reading glasses, and there's no harm in using them, but they don't change the structural function of your eye. So if you need glasses to read, wear them. If you don't. There's no preventative value in using them or not using them.
Okay.
I hope, has that answered your question? Yeah.
I have a question for Dr. Dreyer. Like you mentioned flossing, and you were saying that it's not recommended anymore, but is it safe to use toothpicks, or is it something, or is there another alternative that we should use instead of toothpicks?
No, the message that I'm trying to send is you should be flossing.
Should.
The whole controversy is not based on science, it's based on creating sensation more than this.
Yeah.
Flossing cleans in between your teeth like nothing else can.
Yeah.
So you have to floss.
Yeah. One more question? Tamara?
Vision-wise, is there a point in time where you should not be wearing contact lenses anymore? So let's say I've been dealing with contact lenses the past 25 years, no issues, works well for me. When I take them out, I would have no idea who anyone is up there, probably right here. But is there a point in time where you should put the spectacles on?
So contact lenses, like any kind of form of vision correction, they're not risk-free. There's a risk of a contact lens-related infection that's related to the amount you use them. And that risk is the same no matter what age you are. It's to do with the hygiene with which you use the contact lenses. So there's no point at which you should or shouldn't be using contact lenses, but I think contact lens hygiene is a significant issue, and many of the preventable permanent vision loss problems that we see are related to contact lens related infections, and that's simply related to the amount of time one's wear contact lenses, and it's the same risk the first year as it is the 20th year. Does that make sense?
I have a question for you, Dr. Lobier, in regards to problems with lifestyle-related illnesses such as diabetes, hypertension. What are some of the problems that they can bring on for the eyesight?
Diabetes particularly is very relevant, and the commonest cause of preventable vision loss in the working age population, so in the under 65s, is diabetic retinopathy. We're, I hope, trying to introduce a screening program for every diabetic in Cayman, and certainly the message should be that everyone in Cayman with diabetes should be seeing an ophthalmologist once a year. And we take photographs of the retina, and we can pick up problems with vision related to diabetes early. And we shouldn't have anyone going blind from diabetes on island if picked up early. Having said that, I've seen some awful situations here with diabetes and diabetic retinopathy, and that's often when we haven't picked up people with diabetes early enough. So that's a very important message that we should be getting out to everyone with diabetes. We should be having an annual check for everybody with diabetes once a year. It's a preventable cause of vision loss, and it's still the commonest cause of blindness in Cayman.
Thank you very much. Okay, well, I'd like to thank the presenters this afternoon. We've had some very informative presentations, and I hope that each one of us will take away something that we didn't know before about saving our face. And I'd like to thank each and every one of you for attending as well.